Good evening, everyone. Welcome back to the Journal Club. So, hello for those that may be watching later on the YouTube recording. So today we're in Los Angeles and we're hosted by the Department of Colon Rectal Surgery at Keck School of Medicine, USC. So this is our team. Dr. Glandiak is the editor-in-chief, of course. She sent her apologies. Unfortunately, she isn't able to make it today. This is our disclaimer. This is our first time that we are in California, in LA. And as is my custom, a fun fact about the host city. So California has a lot of natural beauty and of course is quite picturesque. Most people in the world at some point has at a minimum seen it on TV because of Hollywood, and particularly I've seen the iconic views of Venice Beach and the palm trees. And interestingly, what I found out is that palm trees are not actually native to LA, and so all the palm trees in Venice Beach have been imported either from Colorado, desert Mexico, or even the Canary Islands. So that is the fun fact. And now, I'm very fortunate to call on Dr. Kyle Colon, who will talk to us about his city as well as the host institution and the department. Dr. Colon has been in the department since 2012. He is an associate professor and program director for the colorectal surgery residency, and he is also the section editor of the DC&R podcast. And I urge everyone to have a look at this if they have some time. Thank you. Dr. Colon.
Thank you, Vlad, for the invitation, and thanks for everyone. I hope your virtual visit to our city. It's one of the few cities that will have hosted the Olympics 3 times. The next one, of course, being in the upcoming 2028. So a lot of the Olympic trials for the Paris Olympics are going on. So the next time it comes around, it'll be in Los Angeles. One of the venues will be the iconic Los Angeles Memorial Coliseum, which will have hosted its 3rd Olympics, the last one being in 1984, and the one before that shortly after it was built in the 1930s. So we love our city. Our department, we're at the Keck School of Medicine at the University of Southern California. We have 9 colorectal surgeons, including our boss, Dr. Sang Lee, who you will hear from later. He's our division chief and is going to be our invited guest expert for this. So with that, we actually have a couple of satellite institutions. The main one you see here on the left, tertiary quaternary referral center, is the Keck Hospital of USC. The buildings that you see on the right we have an affiliation with the Los Angeles General or the County Hospital of Los Angeles. So a lot of our training programs are affiliated with that. And I will turn it over to our 2 fellows this year, Dr. David Wong and Dr. Sasha Brokard, who will walk us through the various journal articles.
Thank you for this. So these are the photos of the panel. And before we start with the article, just the poll. So please tick what you think is the appropriate answer. The scenario is as follows. So there's a 41-year-old male patient without a family history of colorectal cancer and no prior colonoscopies who presents with fresh painless PR bleeding. And the question is, what endoscopic screening tests would you recommend? Thank you. And whilst that's going on, let's have the next slide. Thank you. All right, so our first article is titled Deep Learning Based Model for Identifying Tumors in Endoscopic Images from Patients with Locally Advanced Rectal Cancer Treated with Total Neoadjuvant Therapy. This paper is brought to us from Memorial Sloan Kettering, with Dr. Hannah Thompson being the first author. We were fortunate to have the colorectal unit feature in our journal club last year, with Dr. Garcia Aguilar being the special guest. So we have Dr. David Wang, who will present this paper, and then we'll have some special comments by Dr. Colon. Thank you very much. Dr. Wang, start when you are ready.
Thank you for having us. So this is a visual abstract from this paper. It gives a nice summary of the study and the findings, and I'll go over that in more detail in the next slides. So the background of the paper is that watch and wait surveillance is qualitative and can vary from surgeon to surgeon. So endoscopically, a complete clinical response is defined as a white scar with telangiectasia without any ulceration or nodularity. The authors wanted to look at a technique called convolutional neural network. It's a type of deep learning that can detect features which are not necessarily visible to the human eye. And the goal being that if they're able to develop a CNN model Sometimes this would be an adjunct to help detect a complete response versus a recurrence in locally advanced rectal cancer patients who are undergoing TNT and being considered for watch and wait. The study was conducted at Memorial Sloan Kettering Cancer Center. Patients were recruited from December of 2012 to July of 2017. They included locally advanced rectal cancer patients who underwent TNT. And notably, most of them underwent induction chemotherapy, and just a few handful underwent consolidation. They took endoscopic images before TNT, during TNT, and after TNT, with the average post-TNT being about 6 weeks. If there were multiple images, they selected the 3 best images with the highest quality. And then all the images were grouped into a no tumor pile and a tumor category. And then furthermore, they were divided into a training set, which was used to develop the model, and then a testing set to basically validate the model. The technique that they used was called threefold cross-validation, which is a machine learning technique in which they go into more detail in the supplemental materials. The way they evaluated the performance was using the area under the operating characteristic, otherwise known as AUROC. So the study included images from 109 patients in total, 82 of which were used for the training set, which included about 1,100 images, and then 27 patients were for the testing set, which was about almost 300 images. And then they looked at the AUROC, which was similar between both groups. There's no statistical difference. You can see the various sensitivities and specificities of these 2 different groups, and then also the positive predictive value and the negative predictive value. So the positive predictive value was around 0.7. So what they found was that CNN was less successful at identifying images with no tumor, and they found that there was actually better performance when they removed some of the low quality images from the set. And some of the examples are included on the right over here. You can see if there's some stool in the image that hampers the ability of the CNN to detect no tumor, or in B, where you see a little tattoo mark there. And then C and D included natural folds that we see in the bowel lumen, which can also affect the performance. And then in E, the image has a bit of a white shine to it because of the glare from the light, and that could be also misinterpreted. And then in F, the image shows some blood. So all of these findings, unsurprisingly, affected the performance of the CNN. There have been other studies that are assessing the surgeon's accuracy in detecting a complete clinical response, and it showed very similar AUROCs in the 0.8 to 0.88 range. And they also found in these other studies that surgeon accuracy was lower when trying to identify an incomplete response. Some of the limitations the authors acknowledged was the retrospective nature of the study that was conducted at a single center. There were a small sample of images, and then they also excluded patients with local regrowth and pathological complete responses, which in this complex topic are an important factor. So in conclusion, CNN was able to achieve a high accuracy in detecting tumor presence, but only a reasonable accuracy in detecting tumor regression or no tumor. There were similar AUROCs in both the training and testing sets. And so in conclusion, a larger testing cohort is needed to refine a model for more complexability and also for more generalizability.
Thank you very much for that wonderful summary. Dr. Colon, could we please have a couple of comments from you? Thank you.
Yeah, I think this is an incredibly important and yet incredibly difficult topic, because as we start to do more watch and wait, we're going to start to look at these things. So the 3 areas that one is considering when doing watch and wait is lack of tumor on endoscopic views, lack of a palpable tumor on digital rectal exam, and lack of tumor on any sort of imaging technology. You really need all 3 to consider it a complete clinical response. And so I think these techniques and technologies are going to get better. I know there's another DCR paper that was published in 2023 looking at the same AI for MRI reading, and not surprisingly, that one showed that the computer was better than the doctors, the radiologists were looking at. And I think you have to combine all these modalities to get a better improvement. The interesting thing I saw about this was it was really they look for 2 years, and I think that's not quite long enough to really know this, because you really got to stay on top of these people going forward. And I agree. I saw a comment in the chat that the static images, the still images, are incredibly difficult to interpret. I think if you had a video with a high definition, sort of see how it moves in real life, that becomes a lot easier. We get a lot of these referrals, and you get this Rorschach black and white diagram of the picture, and you have no idea what it's looking at. So really looking in with your own eyes, I think, is key to figuring all this stuff out. But this is just the tip of the iceberg. You're going to start to see more and more of this in the future.
Thank you. Yeah, I can identify with some of those referrals. Some of the referrals I get still come on fax, and you have a faxed report, which makes absolutely no sense in terms of the subtleties. One of the reasons I chose this topic for you guys is obviously you're quite innovative in your approach to endoluminal management of polyps, and clearly AI seems to be evolving in this space. So have you started using it, and how do you see it helping yourselves?
There's a lot of AI technologies for identification of polyps. We had trialed a couple of them, and if you look at really the way AI works, you need vast amounts of inputs. So it's getting better. The one we had trialed a couple of years ago, I sort of nicknamed the mediocre intern, because it was not great at finding these polyps. But again, as the technology gets better, the algorithm gets better, the computer's going to get better, and that's the future. And I think as we look at quality metrics, that's going to factor into your own endoscopic experiences. It can be used as an adjunct, but at the end of the day, you're going to still be responsible for your quality metrics.
Yeah, that's interesting. I've started, there's one hospital where I scope that have the AI capability, and I've started playing with it. I'm yet to feel that it's made any clinical difference. But I do think it kind of has a Hawthorne effect, where I feel that there's someone behind me watching, and so I feel that I'm looking more attentively for polyps. But most of the things that I have identified with the help of this thing are 3 millimeter, relatively meaningless things. Now, I'm going to just change the question a bit. I guess looking at this study, I tried to decipher the numbers needed to treat to make AI actually a useful thing. And at least in my understanding, or my limited understanding of AI, it is hard to understand this. But in terms of an endoscopist, or a surgeon performing endoscopy and laparoscopy, how many cases do you think one needs to at least become competent at identifying the subtleties in either watch and wait, or in your case in polyps, which are more proximal in the colon?
Yeah, I think this gets back to what we said earlier. This is an incredibly difficult thing to do. So I've looked at things where I would swear there was residual tumor there. You take them to surgery, and the final path is YPT0N0. And I've looked at others where you look at it and you say the opposite. You think, oh, there's for sure nothing there, and there's residual tumor. So it's an imperfect science. I think the classic things of, just a flat white scar with some telangiectasias and no palpable tumor, it's great if you see that. But I think that's not most of these things what we're looking at.
Thank you. I guess one last question, and that may be a segue to our next paper. And please, if anyone on the call wants to make more comments, please do so, and of course we'll discuss them. I guess stepping away from the rectum and going more proximally into the colon, if you have an atypical polyp, whether it's AI identified or you've identified it yourself, what are the features that makes you decide whether you would biopsy it, or snare it straight away, or whether you would, wake the patient up, restage them, discuss them at a meeting, and then proceed with an advanced technique?
Yeah, we looked at our own experience with this, and we found that there's two factors predictive of not being able to do an endoscopic resection. One is it's cancer, not surprising. The second is you've messed around with it a little bit, and that can be as simple as biopsies. So I take the approach that I tell our trainees and anybody who comes to us, it's like what Yoda says, do or do not. There is no try. If you're going to decide to take it out, you got to do the whole thing. And if you're not prepared for that, you don't have the right equipment, you don't have the time, just leave it alone, take good pictures of it, and come back another day.
Thank you very much for that. So I guess on this note, let's move to the next paper. Thank you. This paper is titled Full Thickness Laparoendoscopic Excision for Management of Complex Colon Polyps. It comes to us from the host institution, and I think we've got three of the authors on the call, of course, Dr. Colon, Dr. Lee, and I think Dr. Shin as well. So we'll have Dr. Brocard present the paper, and then we'll have some expert commentary by Dr. Shea. And then we'll have the rest of the authors hopefully contribute as well. Thank you. Start when you're ready.
Thank you for having us. So this paper kind of begins in the fact that benign polyps are increasingly being detected due to increased surveillance, increased screening, and with the advent of AI, more polyps being detected. And there's actually an increase in the number of colectomies that are being performed for non-malignant polyps. And we all know that the risk of a formal resection are obviously greater than the risk of resection with less invasive techniques if those less invasive techniques are done appropriately. So being able to do them without a formal resection, treat these benign polyps without a formal resection has a great benefit for patients. Despite the advances in endoscopic techniques, including ESD, endorobotics, many patients are still treated with anatomic resection, whether it's because those techniques are not available to the endoscopist or because those techniques fail. So there's quite a bit of data and history for hybrid approaches, but there's lacking comparative studies between hybrid approaches and traditional formal resection. So the two known kind of commonly described hybrid techniques are cells, so combined endoscopic laparoscopic surgery, and flex, which is what this paper focuses on is full thickness endolaparoscopic excision. So the methods of this paper is pretty simple. It's a retrospective case control study from 2015 to 2020. The population is 22 patients who underwent this technique, the full thickness laparoscopic excision, versus being compared to 22 patients who had a formal segmental resection. In this paper, they did propensity score matching for age, sex, ASA scoring, BMI, anatomic location of the lesions, as well as prior abdominal surgeries. The primary outcome was the inpatient length of stay. Secondary outcomes that were reviewed include rate of complete excisions, operative time, and post-operative complications. So in terms of a little bit more of this technique, it includes a single procedure intraoperative step-up approach to being able to resect these polyps. So it begins with endoscopic evaluation for the possibility of advanced colonoscopic procedures, including EMR or ESD in a cells type maneuver, so being able to endoscopically completely clear the lesion and monitoring it laparoscopically, or a flex type procedure where you're doing a full thickness laparoscopic excision and monitoring endoscopically, to a segmental colectomy, which can all be done by one surgeon within the same procedure. So it begins with evaluating what the best technique and what least invasive technique will be for resecting these polyps. It can include colon mobilization to set up the subsequent resection of the benign polyp. We have some pictures showing a little bit more about this. So once you have your colon mobilized and you have your polyp endoscopically visualized, you can place some sutures laparoscopically and elevate the lesion. once you have your lesion elevated, you can, with a endo-GIA stapler, you can take a transverse wedge resection, making sure not to narrow the lumen, and monitor it endoscopically that you're getting complete excision of the polyp with negative margins. And then after you've done your resection, you can confirm that your colon lumen remains patent following the flex procedure. So a little bit of the results of this paper in terms of the pathology that's being resected. Something to make sure is that you do want to evaluate these lesions endoscopically to make sure that you're not attempting these procedures on cancers. So this paper did show the majority, 90% of these lesions were benign lesions. The majority were right-sided lesions. The median number of staple fires for these flex procedures was 2 fires, so you aren't always able to take it in one staple fire. In terms of the post-operative outcomes, the primary outcome was length of stay, so there was a statistically significant decrease in the length of stay with flex procedures versus traditional segmental resection. There was a decrease in the 30-day morbidity, and the operative time was expectedly lower, although still 90 minutes in terms of the median time for a flex procedure, and there were no leaks in either groups. So in terms of conclusions and discussion, it does show that this type of step-up approach and single procedure offers colon preservation for select endoscopically unresectable patients with flex procedures, and that some patients can avoid the morbidities that are seen here comparing in terms of lengths of stay and other known morbidity of resection. In terms of the number of patients which this paper doesn't necessarily evaluate, as the number of patients who were approached in a step-up approach and then underwent formal resection and weren't amenable to a flex type procedure. That rate in other papers is about 6 to 10% of patients who are approached in this step-up single procedure style and do require a formal resection. So there is a kind of a small percentage of patients who do undergo formal resection. And when you're seeing these patients, something that's stressed is kind of the importance of determining what brought this patient to you and who called them endoscopically unresectable and why was that. So there are some features that are kind of more amenable to hybrid resection. So if it's a scar from a prior resection, that's something that's very amenable to a flex procedure that may not be endoscopically resectable. Folds can be maneuvered with laparoscopic instruments. Its proximity to the ileocecal valve with cannulation of the terminal ileum those risks can be avoided. In terms of some more concerning lesions that make lesions more difficult for flex, mesenteric-sided lesions make them less amenable, and large longitudinal polyps, which increase the risk of narrowing following your flex procedure. But paper shows that this type of approach is safe and feasible for select complex polyps, and just states we need a little bit larger and more prospective studies to further evaluate.
Thank you very much for that. That's a great summary. Now, can we please have some comments from Dr. Shea?
Sasha, thank you for discussing this paper. I wanted to just clarify with you a few things about what makes polyps appropriate for this kind of procedure. Could you just elucidate on that?
So I think it's up to how you're evaluating it based on what you think the risk of finding malignancy in this polyp is. So anything that has kind of central ulceration or firmness, I don't think those are the ones you want to do. Also looking at other types of lighting to see what the pit pattern is, and those are kind of the main ones I would see in terms of making sure that you're resecting benign polyps.
Yeah, absolutely. And I think it's a really great opportunity for our trainees to really master the Kudo classification scheme for pit pattern identification. Also looking at the NICE classification scheme for NBI and how to use the NBI button for your advantage to see if these things are potentially advanced versus very clearly benign or non-threatening. The other really important aspect, I think, to remember is that this is a prime opportunity to have a good conversation with your referring physician. A lot of the referrals, you'll find this as soon as you get out in practice, a lot of the referrals that we get are of variable reliability as far as whether or not something is endoscopically resectable or not. You may have one endoscopist who's very experienced and will be very detailed about the location on the right side of the colon or behind a fold, and he'll tell you exactly where it is and why it's not resectable, whether or not they provide color pictures or just the fax ink blots. And then there are other endoscopists who, if they know they're going to not have adequate time or equipment or even just can't spare the effort for that time made, they might send it to you straight off. And so the step up idea is really important for this, to know and to explain also to the patients that you are not necessarily signing yourself up for a fancy procedure. You could just do a full bowel prep and get ready for the OR and come out of it with a polypectomy from a regular standard colonoscopy. So understanding the criteria and understanding who you're talking to is really important. One of the criteria that the paper mentioned about what makes something more amenable to these advanced procedures or not is the side of the colon, the thickness of the colon wall. And you can certainly imagine how, if you're in a very thickened, scarred, maybe previous diverticulitis kind of left-sided colon lesion, how difficult it may be to manipulate the wall and to excise this polyp without causing any significant like compression or narrowing of the lumen, versus something on the right side, which may be a little bit more flexible and easier to mobilize for you to get one or two staple fires across without really changing the shape of the colon conduit. I also wanted to mention that there was note of recurrent polyp in 2 out of 22 of the cases. Is that right? Yeah, something like that. Is that an acceptable risk of recurrence, in your opinion, for a technique like this?
I think it is. I mean, in terms of these polyps are large polyps that are being addressed, that if they were attempted endoscopically, the rate of recurrent polyp would be higher than that, and you're still able to spare these patients a colectomy for this polyp.
Yeah, absolutely. And I think that's another really good point when you're educating their patients about this and talking to them about this so-called newfangled technique, where they may have been sent to see the surgeon for a colectomy from the get-go, is saying that, yes, there is this chance of recurrence, but if you're talking about various techniques, sometimes piecemeal EMR can get a high of a recurrence rate as 50%. So I think, less than 10%, 9-10% is not bad, and certainly worth mentioning to the patient.
It's not just the recurrence, though, right? Great. Well, thanks for inviting me, by the way, Vlad. But what the recurrence implies, right? So if you look at cells data from our previous studies, and this also, the recurrence and residual polyp, it just tends to be small, limited polyps, residual polyps that you can, during screening or surveillance colonoscopy, you can just either biopsy, cold snare, and really to complete completely remove whatever that's remaining. So it's not like a recurrence where you need additional surgery or anything like that, but just in surveillance you can take care of that. So it's not really a significant residual recurrence.
Thank you. I've got a couple of questions, if that's okay. There's a question from Dr. Chirocco in the chat, and I have to say that it's a common point, which is the counterpoint to ESD, with a concern for perforation, or I guess to a lesser extent maybe flex procedures. He makes a comment about potential risk of peritoneal seeding if you resect a cancer that way. What is your counter argument to those risks, as opposed to doing a conventional segmental resection?
Yeah, I can answer. Yeah, I mean, for example, flex, when we're doing the removal, we're removing it without disrupting the colon wall, right? So obviously, if there's a tumor there, and if you come across it with a stapler, that's bad, right? But that's not what we're doing here. We're staying away and removing it, knowing that it is benign and the chances are very small. And in the cases where we ended up having a on a final pathology cancer, and we do go back, and that's one of the things that you need to talk to your patients about, that, yeah, we did cells or flex and we got everything out, but the final pathology comes back as cancer, then we have to take you back into a proper resection. And certainly that's has not been a problem. And these tend to be early cancers, right? So if you on the surface looking at morphology, they look benign, and then you remove it and remove it in a piecemeal, just like removing piecemeal fashion for polyps and having cancer there, and also look at the ESD data. It's pretty unlikely that you're going to spread the tumor, but I mean more so with the flex, because you're really removing it completely away from the polyp without disturbing the colon wall. So I think it's a theoretical concern, but it's not really real concern.
Thank you. Now, I've got a couple of other questions. I'm not sure who to direct them to. So maybe, Dr. Lee, I'll direct to you, and then you can quarterback them to whoever you think is best to answer it within your team. So in this study, there are sort of 22 cases described, and they're all essentially right-sided, meaning from cecum to distal transverse. Now, is there a reluctance to do left-sided resections because of more luminal narrowing, because of diverticular disease, or because you feel that you can get to it with, over the scope, sort of new technological devices and remove things intraluminally?
Yeah, I mean, we do see more complex polyps on the right side of the colon, as well as transverse colon. I think a lot of it has to do with that, just prevalence where the complex polyps are located. On the left side, though, if you have a large polyp there, it's a lot thicker colon wall, so it's a little bit more difficult. And so also it's a narrower colon channel, right? So not as easy sometimes to do a flex procedure. Tend to do more of like a lap assisted endoscopic EMR type of procedures there. But sometimes, especially if it's anterior lateral lesion, it's also amenable to doing a flexible procedure. But I think that in our data, it's more reflection of where the complex polyps were located in our series.
Thank you. Now, Sasha, in his presentation, he made a great point about mesenteric side polyps, and that was one of my questions in terms of the difficulty of managing those. But in that point, like, how do you know if a polyp's on the mesenteric side? Do you then subject people to a diagnostic laparoscopy and then decide at the time of that surgery, or is there another way?
Yeah, so a lot of times ahead of time how likely that you're going to either do a colonoscopy to remove it, because sometimes they present with a complex polyp. You scope and you're able to remove it, EMR, and then you're done. You don't have to do any laparoscopy. But also at the same time, you see, looking at the pictures, way it's growing with respect to the fold, or how big it is, where it's located, the chances of doing a combined procedure, or sometimes I would start out with the laparoscopy first to mobilize the colon and figure out where it is, and then scope. So in those settings, you'll know, I mean, by only way to really know is by doing laparoscopy and colonoscopy at the same time. But based on, just doing endoscopy or the endoscopic images, you're not going to know for sure. But if it's in the mesenteric side, you can do lap-assisted polypectomy for sure. If it's a thinner patients, I have done sort of dissection in between mesenteric vessels and get able to get a wedge resection doing a flex procedure. But obviously that's a lot more difficult to do.
Interesting. So further to this point, I guess, is the question of manpower. Now, does this require a two-surgeon approach, with one being in charge of endoscopy, one being in charge of surgery, or do you do this all yourself? What's the logistical planning that goes into this?
Maybe Sasha can answer that question. He's done a few of these with us.
So yeah, I think, I mean, it does require a certain an endoscopist and a surgeon to do at the same time. I think even with some residents, it can be difficult to do this unless you're just having someone hold one and switching, and you're going back and forth from the top and the bottom with a skilled assistant. But to do it efficiently, I think it requires an endoscopist and a surgeon.
Thank you. I guess the flip side to that is you have a patient with far less morbidity in terms of, you know, sort of a bowel resection and a risk of that. Now, maybe one other question in relation to the endoscopy. Now, I assume the endoscope is left inside you when the laparoscopy is performed. And how do you secure it so it doesn't move in or out? That's one thing that I found very challenging in the sort of in the cecal polyps that I've tried to attempt in this manner.
Christine, you want to answer that?
Sure. I think that's where having a appropriately skilled endoscopist really makes a difference. I mean, I think it's really beneficial to have at least a fellow level or above endoscopist down below, so you can worry about the laparoscopy part, because there are certain maneuvers that can be a little bit difficult for the more novice person who's scoping, such as if you have a lesion that's very close to the appendiceal orifice or to the ileocecal valve, more importantly, where you can actually use the scope as a bougie to stent open the ileocecal valve and get a better sense of where the folds are, especially as you come across the area with the stapler and start to change the conformation of the cecum. So as far as holding the scope still, you know, just get steady hands and a couple of gauze and towel around so you don't slip out of your grasp. But
Also, laparoscopy can help a lot advancing the scope without having a lot of, you know, creating a lot of loops. So as you're guiding the scope, you're just getting accordioning the colon over the scope, so you don't have a whole lot of loop, and you don't have this like you know, hysteresis in terms of moving in and out of the colon, and you sort of draw back. So that's another advantage of using laparoscopic assistance.
Thank
yeah,
you.
And these patients are generally positioned in lithotomy, so you may not have the luxury of really directed abdominal or sigmoid pressure and trying to navigate the scope through. So having someone who has a sense of being able to watch both screens, both interluminal and through the abdomen, can be very helpful as far as applying the appropriate amount of torque and tension on the scope to get it through safely. And of course, it's really instructive for the people who, I remember when I was a fellow doing these cases with Dr. Lee, the first time I saw a scope pass through the sigmoid colon under direct vision from laparoscopy, you think the sigmoid colon is just going to fall apart in pieces. And so it's really nice to get a sense of how much trauma the colon there can tolerate and what you can and can't do to it.
Thank you. My last question before we move on is, I guess, particularly for people that would want to start doing this, what is the target market? Particularly what patients? Like Sasha's comment about removing scar, I thought is very interesting. I haven't thought about that, but that seems like a very useful technique for that. But how would you recommend for people to start this in you know, a hospital elsewhere?
I mean, if you think it's a benign polyp, because a lot of times it's not always a large polyp. How many times have we done a colectomy and you look at the specimen and you go, wow, I did a whole colectomy and it's like a tiny little polyp. It's in an awkward position. So it's something that you can try, but the other side of it is this, you know, whether we do it or whether it's appropriate or not, you know, their whole, you know, movement, you know, there's a whole new technology, new technique that gastroenterologists, whether we like it or not, remember, they are the ones who control the patients. So those patients may not ever get to us if we just keep doing colectomy, right, for these polyps. So we got to figure out something different, something better for our patients. And I think that's one of the key takeaway points for all of us.
Thank you. I think that's a fantastic point to end on. Now, the next slide is the results of our poll. And so, again, the question is 41-year-old male patient without a family history of colorectal cancer. or prior colonoscopies who presents with fresh, painless PR bleeding, what endoscopic screening test would you recommend? And the reason I brought this question up is because one of the papers we've also featured this month on social media is called Assessing Guidelines on the Need for Colonoscopy After Initial Flexible Sigmoidoscopy in Young Patients with Outlet-Type Rectal Bleeding. So, Stephen, can you please just summarize the comments, and then we'll discuss it with the panel? Thank you.
Yeah, there was a strong preponderance of always colonoscopy for this 41-year-old. And then a small number of physicians that would do a FlexSig first, optional colonoscopy, and then some that would do a FlexSig. I think that probably the distinction between those might be a little gray.
Thank you. I guess this may be more relevant in overseas, but this paper is from New Zealand, and certainly in Australia it's a similar issue where the public healthcare, so our universal healthcare, is very stretched, and so it is difficult to arrange timely colonoscopies, and we kind of try to triage people logistically, and so that's one of the techniques that's been proposed, and the authors do comment about, or they state that they decide on colonoscopy based on sort of risk factors like 3 or more adenomas, sessile lesions seen on flexible sigmoidoscopy, more than 20 hyperplastic polyps, or a large polyp of greater than 9 millimeters. I guess in your center, would you automatically just proceed to colonoscopy with these patients, or do you titrate based on presenting complaint?
Christine?
I generally try to gauge the patient's duration of symptoms and the severity of it. Quite often I have patients who are coming in who've been suffering from their issue with the bleeding for many, many years and have already built up a healthy anxiety about colon cancer or any of the other crazy things that could potentially be causing the bleeding. I generally will take a look with anoscopy first and see what I can make of their hemorrhoids, and also get a better history as far as their bowel habits are concerned, because for the vast majority of these patients, if they're demonstrating inflammation in their hemorrhoid columns and they're telling me they're constipated and just struggling every day on the toilet, then I will see how they do after a trial of some reasonable bowel regimen, and to see if their symptoms do improve, especially if they're, average risk patients and nothing else really, red flag is going on with them. And if that, of course, if their symptoms persist and the anoscopy, or if the anoscopy is relatively ambiguous, then in theory, I would like to just run over to the other side of the clinic and do a FlexSig, but quite often the logistics of that aren't really that amenable to that plan, and so colonoscopy generally ends up being my next recommendation.
Thank you. Is that effectively the consensus? Anyone has any other comments on that? Good. All right. So in the interest of time, we'll move to the next stage, and this is our special guest segment. Very lucky to have Dr. Lee as the special guest. He, of course, is the chief of the colon and rectal surgery and Costello Clinical Professor at Keck Medicine at USC. He, of course, specializes in minimally invasive techniques, and particularly is a leading expert at laparoscopic and endoluminal surgery, where he pioneered endolaparoscopic surgery. Further to this, Dr. Lee is a lead innovator in a surgical negative pressure dressing device, and I'll try to cover both of those things with our questions. And on a personal note, I first met Dr. Lee as part of the advanced endoluminal training course that he runs for colorectal fellows. I met Dr. Colon there as well a few years back now. And certainly I didn't expect to be in a position where we've formed a journal club and we have him as a special guest. So that's quite nice from a personal progress point of view. Anyway, well, thank you very much for agreeing to participate. And my first question is, I guess you have pioneered a non-invasive surgical technique being flex and cells. How and why did you get into this?
I think a lot of reasons. The technique of combining laparoscopy and endoscopy has been reported by others way before. But when we're thinking about it, the CO2 colonoscopy was available, and I think that really made the whole combination of the technique feasible. Because with the conventional air colonoscopy, colon blows up and you're not going to be able to see anything laparoscopically. So when you try to do it with a conventional colonoscopy, there's no way to do that. So we were actually one of the first ones to actually, I think we were the first ones to use the CO2 colonoscopy intraoperatively. And that really facilitated what we wanted to do. But as I mentioned before, we're one of the things that I talk about at the advanced endoscopy course is, the first sigmoid colectomy with anastomosis was done 200 years ago, right? In Paris, patients survived. So after 200 years, and Jeff Milsom talks about it too, one of my mentors, that, after 200 years with the benign polyps, we're still removing somebody's colon and putting it back together. And certainly there's got to be a better way to take care of our patients for benign polyps than that. And if we don't, our gastroenterologists, the colleagues are doing very aggressive, interventional, less invasive treatment for these polyps and other conditions. So I think, doing something that's a lot easier, unfortunately, ESD is very difficult to do. EMR is not universally available. But as surgeons, we're able to do all these techniques and including colectomy. And so we can utilize all the techniques that's available to us. And I think we're probably the best suited to lead the charge in this. So having ability to do this very easily. So, talking endoluminal robots, but it's still not there. Once you get used to it, it's a very easy technique to take care of very complex polyps with much better outcome.
Thank you. I've briefly mentioned the endoscopy course, which I thought was fantastic when I did it years ago. I guess my question is, how do you balance the impartial academic hat or role, which obviously comes with these courses and generally with a academic career, but also with the industry support required, particularly to innovate and try new equipment, and so how do you navigate those sort of deep waters?
I think it certainly can be very difficult, and I think there's a fine balance there. But for example, having a course there, even though they're supporting us, we control what's presented. So the contents are basically controlled by us, not by the industry. They certainly bring their equipment for fellows to try hands-on, but it's really up to the fellows to decide whether it's good or not, or whether it's something that's worthwhile. But I think unlike our medical colleagues, drug companies and their relationships, as surgeons, I think our relationship with the industry and surgical device companies are completely different in that, we have to teach ourselves, right, how to properly apply certain device. So for example, energy device, it's out there, but we have to figure out how to properly use it, and we have to teach each other. So it's a really symbiotic relationship. And then also, having a device, for example, they without us, sometimes you see these versions of devices that's ergonomically impossible to use, and you ask them who thought of it, who tried it, who designed it. That's because one of the engineer guys, right? So why don't you ask one of the surgeons to really get involved and make it properly the right way? So you'll see that. I mean, they can't really come up with a proper device without having us involved. So I think it's a little bit different relationship, and I think we need, both of us need each other to make it successful and to have a best outcome for our patients.
Thank you. I think with ergonomics, my wife is an endocrine surgeon, and she does have smaller hands than me, and she goes on very frequently how some instruments are male sized, so she struggles particularly with energy devices, and I'm very empathetic to the ergonomics of that. Now, my follow-up question in relation to sort of navigating deep waters. Recently at ASCARS, I've had a discussion with a couple of colleagues about kind of the conflict of interest slides. And we all put one. We have one at the Journal Club, but I must say that I find it very difficult to know what to put and what not to put, and how to define a true conflict of interest. Now, you, of course, have many hats in terms of the things that you do. So how do you define conflict of interest, and how do you and what would you declare when you're giving a talk?
Yeah, I think that's a very complicated, difficult thing, because again, when I'm sort of looking back to the way when laparoscopy start to really become popular, right? So when laparoscopy for colon cancer cost trial came out, everybody wanted to learn how to do laparoscopic colectomy. So we couldn't travel the, different parts of the country fast enough to offer all these courses and teach them. So if you're just looking at, well, amount of money that you're getting paid for teaching these courses, it seems like you have this conflict. And if you're just based on that, eliminate those people from presenting at the society meetings, for example, then you're probably eliminating all the experts who are really involved in this technique and technology and teaching and things. So I think there's got to be a better way to really look at it in detail, as opposed to just having based on how much money you're getting from industry. I think really the nature of the relationship and what you're spending your time doing certain things, I think would be very, very important. And sometimes they can be very difficult to so if you're talking about, giving a presentation, and if there's a certain real conflict, of course, those surgeons should not be involved. But I think we really need to dig into a little deeper in terms of what's happening and what relationship that each person has.
Thank you. The next thing I wanted to sort of touch on is, of course, the sort of your strength as an innovator. And I know that you are the lead inventor of the NP Seal, which is a product by Guard Medical, a lightweight suction dressing. So can you please tell us how that came to be, and what you've learned from it, and where is it going?
Yeah, so it's something, well, over the years, I had a lot of different ideas, and then this is one of them. And I think it sort of came together in a nice way by accident. But, if you do, I mean, I think everybody has some good idea, right? So, hey, I could make it into a product or whatever, but to get it into a device that's applicable and have an FDA approval and enough funding to get it into a commercial market, I think it's very, very, very difficult. I thought of it when one of my residents showed me after an appendectomy. He said, "Well, this is I saw this from a pediatric attending. You're putting a gauze and putting a tegaderm over it, and then aspirating the air using a syringe with a needle to create a vacuum inside of it." And I thought it was a genius idea. And at the time, a lot of high SSI and wound complications. The problem is you quickly lose your vacuum once you take out the suction, right? So the ability to maintain it without having to poke somebody's skin and suck out the air, I thought is a challenge, but also it's something that could be helpful. And then when I was thinking about this, other motorized devices, that has generates vacuum and the wound vac converted into a closed incision application. There are companies out there, and then they're actually reporting their results for using it for closed incision. So I thought it was sort of a good timing for less expensive. Vacuum is vacuum, right? So it doesn't matter how you generate it, and it's certainly having a motorized, very heavy device where patients have to carry that around certainly can be very cumbersome. So very lightweight, portable device made sense. So I was working at Cornell at the time, so the invention belongs to Cornell, but I was able to partner with others who had a lot of experience in the business side of it. So we formed our own company, and then we licensed it from the university, and then we patented it later on. But we were able to get a VC money to really get the prototype FDA approval, and then do a trial to show that it works. So we've gotten Series A and Series B funding, and about 60 or 80 hospitals that's tried it and currently using it with a good outcome. So we're in the process of expanding it.
Oh, that's fantastic. Congratulations. It's something that I've sort of been trying to learn to do in terms of innovation and small ideas. And I must say that nowhere in my career to date have I been exposed to medtech development. And so what tips would you have for junior surgeons who may have an idea of how they go about pursuing it and hopefully, getting it to fruition like yourself?
Yeah, no, it's a very complicated and very difficult thing to do. So number one, if you have a good idea, don't, disclose it don't share it with somebody else. So I made a mistake early on in my career. One of my medical student and PA student actually took that idea and create a device that they, and sold it to big company for lots and lots of money without getting me involved. So number one, protect your idea. But if you're working for an institution, your IP belongs to the institution. But thankfully, a lot of the institution also, they do help you to a certain extent, in terms of getting a provisional patent to protect your idea for the first year. So they can help you. They allow you also do a patent search to see whether there are any similar ideas. But I think the biggest hurdle is to get that initial seed money. So depend on the complexity of the device. A lot of the VC companies probably will not going to invest in you unless you have something that they can see and feel. So having an initial $100,000, $200,000 seed money to get the prototype made, I think that's the really difficult part of it. Certainly, there are other angel investors that can certainly put the seed money, but they'll probably take big chunk of a part of your company with a relatively small amount of money. So I think the probably ideal thing is if you have somebody that has experience in the business side of it, you form your own company with a partnership, so that, let's say you partner with another person, then you're starting out with the 50% equity, right, in your device, and then you form a company, and then as you get more funding, you will dilute it, but you will still, at the end of it, maintain a significant portion of the equity, as opposed to if you have a VC that put all the money before you form your own company. The VC owns all of the company, and then at most they'll hire you as an expert in that. So you may start out with the 5 to 10% of the equity too. So that's something that you need to consider. And then also you need to have somebody with the experience, the business side of it, to really help you. Because if you think you can be a CEO of the company and then to make it a success, it's going to be very, very difficult thing to do. Probably not going to be very successful.
Well, yeah, it's certainly daunting, particularly because I think most of us would feel that the cutting is the strong bit. Anyway, it may be a topic for a whole journal club, but I'm finding this idea quite fascinating. But thanks for answering that in such a detailed manner. My last question is I guess also based on your background. I think you have a biomedical engineering degree, and so hopefully you can provide a balanced opinion of this. So I kind of believe that at the moment there's an interaction between hardware development in MIS surgery, be it new laparoscopic or robotic equipment, and software development being AI, which is sort of in the forefront of surgical progress. And when I've attended talks about the medical application of AI, which are predominantly done by non-clinicians, sort of IT heavy people, I find that whilst they describe the technology in a very inspiring manner, I fail to see the connection to kind of clinical medicine. And I guess my question is, what do you think are the bottlenecks of the relationship between in MIS surgery of the hardware development and the AI or software development? Yes.
Yeah, I think whatever the new technology is, it's got to make sense in the context of clinical application, right? So just because you can doesn't really make sense, So, for example, somebody was telling me, yeah, I'm making this sensor that's going to detect this, and then any time of the day or night something goes wrong, it's going to send a signal to the surgeon immediately. So I said, well, okay. I mean, no surgeon in the middle of the night want to learn about this sensor. So even though it sounds like a good idea, I think you got to get rid of that feature, to alert any time of the day. But so I think that's where the collaboration between the clinician. I mean, the AI is great. A lot of things they're being developed. Having enhanced optics or augmented reality that shows you tissue planes and tissue perfusion and predict whether it's a cancer there or benign. And some of the one of the papers that we talked about, I think those are great, but we need to put it in context that makes sense for our patients. And it's really the collaboration.
Well, thank you very much again for everyone who from the host institution, particularly Dr. Lee and Dr. Colon. Thanks to the presenters. We've had a great session. It'll be recorded and available on YouTube. Our next session will be in the end of July, so that's on the last Monday of July, and we're going to have a video analysis or a didactic video session looking at ileal pouch formation and complications of this. So again, thank you all and have a good evening.
Thank you.
Thanks, Vlad. Great job.